This is I believe this is our first ever research day, Jana, outside of our annual LSA meetings, where we have some resident and other research presented. Obviously this year, 2020, we get to innovate, come up with a new plan. So we have an online e-poster virtual presentation format. And I believe, did we get actually 17 altogether, Jana? I think we have 17 presentations tonight. I think that's really great. I'm glad to see you all participated. Bobby Nossaman is on here with us tonight. He's a physician anesthesiologist extraordinaire. He's been doing this for not quite longer than I've been alive, but a long time. And
a while.
I've known Bobby. I knew Bobby 11 years at Tulane. I know some of you are from Tulane. Can you believe that? Both Bobby and I were over there. I was there 11 years and Bobby was there for about, I think, 89 years. And then, and Bobby is now at Ochsner, where I also am at, and he's the anchor, really in a good way, not a dead weight anchor. He's the anchor of whatever research gets done in the anesthesia department. And I know he was participated in some of these presentations for the students and residents. So I'd just like to turn it over to Bobby. The one little change we're going to make from what this says on the agenda is we're going to keep your presentation to the 5 minutes, and then we'll do a little. Keep your presentations to 5 minutes, and we'll do brief questions at the end, a minute or something. And then if you have questions, we can do more questions at the end, but it would be very hard for people to remember every question from the first presentation to wait till the 17th presentation. So with that, I'm going to turn it over to Bobby, and thank you all for being here.
Thank you, Dr. Kowaleski, and to you, Jana, for putting this together. I can see the incredible amount of time and effort in getting this organization up and running. But I'd also like to thank our presenters tonight for the time and effort in preparing your presentation. Presenting complex concepts require a lot of effort, but is really a necessary skill for us in the practice of medicine. Tonight, you advance medicine. Tonight, the floor is yours. Tonight, we will learn from you. So again, thank you. Let's have some fun. And with that, our first presentation is the bilateral thoracic sympathectomy with VATS in a patient with refractory angina by student Dr. Zahir Naziri. The floor is yours.
Thank you, Dr. Nossaman. Are my slides up?
Jana?
Maybe can you click it to the full screen?
You share your screen. Do we need to share screen, or
Yeah,
Jana, do you have?
it's shared. You just need to click it to make it full.
It looks like, there you go.
There we go.
There we go.
There we go.
Okay. So this is a case study that myself and Dr. Jimmy Colon collaborated on involving a patient with refractory angina who underwent a bilateral thoracic sympathectomy utilizing video-assisted thoracoscopic surgery, otherwise known as a VATS procedure. Next. So everyone here knows the typical first-line treatments for angina. But once all of those venues have been pursued and the patient is still experiencing intractable episodes of angina, or if the patient is just not a suitable candidate for the aforementioned for the therapies that we are familiar with, then a sympathectomy can be pursued to provide relief. And the relationship between relief of anginal pain and sympathectomy is related to the physiological connection of the central nervous system to the myocardium via the sympathetic autonomic nervous system. So vasospasms lead to ischemia of the myocardium, and that results in release of activating substances such as bradykinin and adenosine, and those stimulate afferent fibers of the sympathetic nervous system, and then pain signals are then carried to primarily the sympathetic ganglia at the levels of T2 to T6. And these are what are targeted sympathectomies and are what result in the sensation of angina in a patient who has not received a sympathectomy. Next. So here we report the medical history, surgical procedure, and post-operative findings in a 27-year-old female who underwent a bilateral thoracic sympathectomy for refractory Prince-Metal angina. And here I have briefly outlined her most relevant past medical and surgical history. Next. So here I've provided a brief general outline of the procedure, and while I won't be going over it in detail presently, the purpose of the outline really is to demonstrate that the procedure did not differ vastly from those reported in the literature, yet the long-term benefits of this procedure did differ, and that is what the premise of the case study really is. The procedure was performed by cardiothoracic surgeon Dr. Brian Pettiford with Dr. Jimmy Colon as the anesthesiologist on the case, and the patient tolerated the procedure well without any of the frequently reported operative risks of Horner syndrome, pneumothorax, etc. Unfortunately, however, while the patient did experience sustained threshold of her anginal pain for 2 weeks following the procedure, upon follow-up, we found that her pain had actually returned, and she reported to the ED for excruciating chest pain almost exactly 2 weeks after the procedure took place. And to present day, she has also had multiple presentations to the ED as well. Next. So this case is unique in that while thoracic sympathectomy is not a novel procedure per se, we do see it used more commonly for relief of hyperhidrosis, facial flushing, or pain related to Raynaud's, but not quite as often in comparison for angina because there are already many true and tried management options, which I kind of discussed in the introductory slide. So sympathectomy is really reserved as a last resort scenario. And when it is used for angina, they generally provide a high degree of medium to long-term relief in most patients. So this opens up further discussion for future research exploring why some individuals experience complete resolution of symptoms for years following the procedure, while others, such as our patient, experience extremely transient relief with uncharacteristically rapid return of pain. So it opens the door for further exploration of whether better outcomes are seen in procedures where resection of perhaps a sympathetic trunk at certain levels may yield better results than at other levels, or whether it could truly just be patient dependent and differences in anatomy or pathophysiological response of the patient at the patient level could be the explanation for the vast differences in symptomatic relief. This specific case also provides a gateway for exploration of historically unexampled patient populations, such as our 27-year-old in this case. As we know, angina is typically experienced in patient populations over the age of 40, with the majority of cases presenting in patients over the age of 60 due to its association with ischemia, secondary to coronary artery disease. And in the literature I've listed in this slide, which outlines long-term benefits for many patients receiving sympathectomies, the average age of the patients reported was actually over 50 with a slightly male-dominated skew versus the patient in our case who was not only half that age, but was a female. And this is of particular importance because as unhealthy lifestyle habits and obesity begin to rise, so will coronary artery disease and angina in younger, unexampled patient populations, such as our patient. So it is imperative to follow and further explore young patient populations undergoing this procedure in an effort to further delineate whether the difference in outcomes could be due to factors involving age or gender, or other properties of past medical history or past surgical procedures which could affect outcomes in the utilization of thoracic sympathectomies. And if a pattern of similar outcomes to our patient begins to emerge, then perhaps it could be extrapolated that the procedure should be reserved for certain populations over others, so that pre-op prep and procedure recovery time don't kind of outlast the actual time of the benefit of the procedure, and perhaps other avenues of pain management could be explored. And that is the end of my presentation.
Thank you for this presentation. Do you think, would this patient benefit from TENS?
Perhaps, yes, I think this patient could perhaps benefit from TENS.
Thank you again for this presentation. We'll
Thank you,
proceed on to our session 2 of critical care medicine by student Dr. Ayub, presenting a clinical care of adult patients with a diagnosis of COVID in an informed decision analysis scenario. Please begin.
Thank you, Dr. Nossman. Right. All right. So this is the clinical care of adult patients with a diagnosis of COVID-19 and informed decision analysis. This is a retrospective study consisted of greater than 60,000 data point harvest over the course of about 5 months. The data included in this presentation only represents a small fraction of what we ultimately collected, and the analyses and discoveries are continuing to be developed. IRB approval for this study was obtained in March 2020, and there are no financial disclosures to report. Our purpose is straightforward. It's to measure the outcomes of particular treatment modalities in a group of patients who required invasive pulmonary ventilation due to COVID-19 throughout Ochsner Health. Data derived from this study could lead to protocols to improve patient care. 211 patients that were admitted to Ochsner Health between the months of January and May of this year were included in this study. Inclusion criteria consisted of patients that were 18 years or older with a presumptive diagnosis of COVID-19 ARDS who required oral tracheal intubation. We used the Berlin definition for diagnosis of ARDS, which included the timing of symptoms within 1 week, bilateral opacities on chest imaging not fully explained by effusions, lobar collapse or nodules, and respiratory failure not fully explained by cardiac failure or fluid overload. Retrospective chart review was performed using Epic electronic medical record, and statistical analyses were performed using JMP software version 13.2. Next slide, please. Hospital mortality was quite high in our patient population. 136 of the 211, or 64% of our patients passed away in the hospital. When we analyzed certain comorbidities, we found that the greatest risk came from a history of tobacco smoking with a risk difference of 20%. Of note, all those with a history of organ transplantation passed away. However, there were only 5 patients in this subgroup. Next slide, please. On this slide, we have a couple of mosaic plots, one outlining the hospital mortality from patients receiving or not receiving heparin therapy, and the other outlining hospital mortality from prone versus patients that remain supine. The mosaic plot on the left-hand side shows a nice graphic representation of the scale of heparin therapy for this patient population. Heparin was administered to 164 of the 211 patients, with the remaining 47 patients not receiving this treatment. This visual representation shows virtually no change in mortality between those two treatment groups. Of the 164 patients that received heparin therapy, 106 passed away. This is a mortality rate of 65%. 30 patients of the 47 total patients who did not receive heparin passed away, which results in an almost identical mortality rate of 64%. The second mosaic plot that we have on the right-hand side of the slide shows the mortality of patients that did and did not receive proning therapy. Proning occurred in only 42 of the 211 patients, which you can see by the dramatic difference in the size of the two sides of the plot. Even though this intervention was only implemented in about a fifth of total patients, we found that it was associated with a dramatic increase in mortality rate, 83%, about 35 out of the 42 patients. And this is compared to patients who did not receive proning, which is about 169 patients, 101 of them passed away, so only about 60%. our data shows an increase in hospital mortality such that proning increased the risk of death by 23% with a confidence interval of 8 to 35%. This represents a significant clinical difference. Next slide. So this graph shows the 7-day serial progression of the nadir and oxygen saturation of prone patients, which are the blue dots, versus non-prone patients, red dots, who either expired on the left-hand side or survived on the right-hand side. It's a very busy graph, and I apologize that the data points are hard to see, but the key finding here is that there is no apparent pattern for the decision of proning the patients. Next slide, please. And in conclusion, we found that the greatest predisposing factor in mortality to be a history of tobacco smoking. Heparin was not found to be a beneficial therapy to prevent hospital mortality. Proning patients was not found to be beneficial. In fact, our data suggests that it may actually be to a detriment to mechanically ventilated patients with a diagnosis of COVID-19. Limitation of our study included small sample sizes for some of the subgroup analyses, such as those who were prone versus not prone. These results suggest that further study is warranted regarding the efficacy and safety of existing interventions. Thank you very much.
This paper is up for discussion.
I'm sorry.
Did you find any therapy that was beneficial for these patients?
We are still investigating that. I believe, I'm sorry, I'd have to get back to you. I need to review some of the antibiotic and pressors that we looked at as well.
All right. Okay. We'll proceed on to our next section, fundamentals of anesthesiology. Dr. Anwar, excuse me, is going to be discussing severe orolingual angioedema after a thrombolytic therapy in a stroke patient. It's a case report. Dr. Anwar.
Thank you, Dr. Nussman. So I'm presenting this interesting case along with Dr. Catherine Cox, our program director, who was directly involved in taking care of this patient. We had this gentleman who presented with severe orolingual angioedema, causing airway compromise after receiving TPA at an outside hospital. And as you can see in my title slide, there's a book you can easily find on Amazon. This neurologist called Justin A. Zivin. He's from California, and he wrote this book a few years ago regarding how neurologists for a long time were scared of prescribing TPA, despite the documented benefits. There was a lot of concern among the medical community about the side effects that TPA can have, and how challenging it was to convince physicians to prescribe this therapy. So if you want to learn more about that, you're welcome to read this book. I found it really interesting. Next slide, please. So our patient was a 48-year-old African-American male who had a past medical history of Down syndrome, diabetes, hypertension, and he was taking ACE inhibitors. He received the TPA bolus for a left MCA stroke at an outside facility, and then he was transferred to Tulane. We were told when they transferred him from the other facility, he did not have any lingual swelling, but when he presented in our ER, this was his first picture before any intervention. As you can see, that he had this massive tongue swelling and severe orolingual edema. His blood pressure and all the vital signs are mentioned over here. Anesthesiology was consulted by the emergency room department, although at Tulane, most of the ER physicians, they do their own intubations, but obviously this was a challenging situation for them. So they consulted us for intubation and securing the airway in an emergent situation. Next slide. So the patient was emergently intubated using the fiber optic bronchoscopy with minimal sedation and only a dexmedetomidine. Afterwards, he was taken by neurosurgery for an emergent thrombectomy. Post-operatively, the patient's orolingual angioedema was manage using racemic epinephrine, hydrocortisone, methylprednisolone, decadron, antihistamines. He got several botulinum toxin injection to the medial pterygoid muscles, which is a well-documented treatment for this condition in the literature. One of the all after regardless of all of these conservative management, the patient's tongue swelling did not improve after several days, and the family was offered partial glossectomy, but they refused surgical management. The patient was discharged afterwards to an LTAC after almost staying 54 days in the hospital, where I later found out that he passed away from some unrelated complications. Next slide. What happened to this slide? So I think that this thing is missing a slide. There was supposed to be a picture over there. Jana, do you mind if I share my own screen? I don't know why it's not showing over there.
Please
I don't
share
know
your
why
screen, sir.
either, but yes, you can.
Yeah, give me 1 second. Sorry, guys. I don't know why it didn't show over there. All right, can everybody see this?
Yes.
All right, so this is like one of the pathways that I wanted to share with everybody, and I'm sure most of the people already know just the way the TPA works. TPA stands for obviously the tissue plasminogen activator. It breaks down plasminogen to plasmin, and then plasmin breaks down the clot. The plasmin can at the same time activate several other pathways. It can also activate the complement system. It can activate the kallikrein pathway, and the end result is there is a huge surge of bradykinin production. The studies have shown that there is a mild to moderate risk of angioedema ranging from 1.3 to 7.9% among the patients who has had a history of stroke. Although that same risk is pretty negligible, about 0.02% in the patients with myocardial infarction. And some authors have suggested that there's an inherent increased risk for oral-lingual angioedema in the stroke patients. And then at the same time, if you look at the bottom of the pathway, the way angiotensin converting enzymes inhibitors play into causing more oral-lingual angioedema is they inhibit the conversion of bradykinin, or basically the breakdown of bradykinin. So our patient in this scenario, he had stroke, and he also was taking ACE inhibitors, which also contributed to the severe angioedema. Last but not the least, so most of the time, conservative or symptomatic management is what offered to most of the patients, since most of the cases of the oral-lingual angioedema are mild to moderate. I think that's what was surprising, especially in our case. It's highly unlikely that patients will have severe angioedema causing respiratory compromise, which is what happened to our patient. In some instances, you can use FFP. FFP has C1 esterase inhibitor, and you can go back to the pathway. You will see that because of the complement activation, that can also contribute to the accumulation of bradykinin. So in some scenarios, you can use FFP, and the C1 esterase inhibitor will increase the conversion of or decrease the activation of that complement pathway. Some of the two novel drugs that are used occasionally in these patients is ecllantide, which is plasma kallikrein inhibitor, and icatibant, which is a bradykinin receptor blocker, which directly acts on the bradykinin receptors. These are kind of expensive drugs, and they are approved by FDA, but they're not widely available. And last but not the least, the most I think the definitive treatment for a severe oral-lingual angioedema is partial glossectomy, which our patient's family didn't go for. Thank you very much. I invite any questions.
You have a question. I am going to open Dr. Aaron's microphone to allow his question. Okay, go ahead. Oh, he's muted.
So yes, I'm reading the question. It says, was the angioedema attributed to the TPA or the ACE inhibitor or both? Yeah, so that's what the whole idea of this case presentation is, that ACE inhibitors by themselves can definitely cause angioedema, but this level of severe angioedema is not reported just by the ACE inhibitors. And this patient was already taking ACE inhibitors for a long time. It was not like he just got started and he had this acute side effect. So it was definitely not just his ACE inhibitors. He got the TPA bolus for the treatment of stroke, and that's when he actually developed this oral angioedema. And our purpose was to present and make everybody aware that you should be cautious in treating this patient when you have a patient presenting with stroke and they're already on ACE inhibitors. So you want to be really careful while giving them TPA, because both of these drugs can have synergistic effect in causing that bradykinin surge.
All right, looks like we have another one.
So trisomy 21 contribute. Yes, it can, Dr. Eagleton, but I don't believe the trisomy 21 can cause angioedema. As far as I know that this patient, although he had Down syndrome, but he didn't have any history of respiratory difficulties from that. Yes, I believe the ACE was stopped, although it was not like the TPA was continued. So which I think was the primary reason for this patient to develop this disease process. He was in the hospital for a long time, and as far as I remember, he did not receive any ACE inhibitors while in the hospital.
Any other questions? Dr. Nossman, we had a question for the last speaker. I didn't know if we wanted to go back to him.
Brad, Aaron, I'm now seeing the question. Was there selection bias in the proning the sicker appearing patients who were failing other therapies? That's a tough definition of sicker, because they were all incredibly ill. And it was mind-bending experience in taking care of this patient population back in the spring. So the question was raised, as we didn't have effective protocols other than the critical care medicine protocol that was out on ARDSNet. That was our initial approach, and we found quickly within the first week, 7 to 10 days, that the high peak was not working in these patients and causing a lot of hypotension and vasopressor support. And so again, those patients, the 42 that underwent proning, we scurried through the charts to see if there were measures of why these patients were prone. Well, generally it's hypoxemia as detected by the pulse oximeter or a very poor arterial blood gases. And we limited our blood gas drawings. We limited lab during this period. So we basically went on pulse oximetry, and I believe, although we could not see a pattern of hypoxemia based upon the naders that were being reported, I believe there were decisions made by individual teams across the 7 units that were holding COVID patients, that some of these patients did undergo proning in an attempt to improve their oxygenation. To my surprise, when we looked at this data from 1,000 yards, that the mortality rate was a dramatic increase. When this data were presented to all of our intensive care unit staff throughout the oxygen healthcare system, we were all astonished. That's my best answer. With that, we'll do our second fundamentals of anesthesiology presentation this evening by Dr. Wesley Stowe, pharmacoeconomics of IV versus oral acetaminophen and ERAS protocols. Dr. Stowe.
All right. So this is mainly looking at the pharmacoeconomics and how, as anesthesiologists, we have a large access to medication that we give patients, and ultimately what they're charged for and what the hospital buys. So this specifically was looking at Tylenol and IV versus oral, and then what's its effects on patient outcomes were and have been in other research versus the cost of it, more specifically at our hospital, what it costs there. You can go ahead and go to the next slide. So purpose, like I said, as anesthesiologists, we control a significant portion of the medication that we use, and we can affect medical costs and medication use within the hospital on a large scale. The main purpose of this is to improve, train, and gain some knowledge on some medication utilization during surgery and the perioperative period and how it'll affect patient outcomes. All right, so cost of acetaminophen, the IV versus the oral. So the IV acetaminophen costs approximately $40 per dose, and what we actually end up charging the patient is about $130. An oral acetaminophen tablet is about 3 cents each. So you can look at this on a large scale. In the US, there's about 40 million anesthetics that are done each year. To say if that Tylenol was being used as part of this multimodal approach, that you'd be spending around 1.6 billion on IV versus oral. And then patients would be charged 6.4 billion. All right, you can go to the next slide. So you'd think that with this large increase in money that there'd be a significant portion of improvement in patient outcome. But more recent studies have shown that it's really not that way. And this graph below is actually taken from the OfferMed website itself. And a lot of research shows that using the Tylenol oral in the perioperative period, 24 hours before they even get there, starting them on a regimen of, say, 1 gram every 6 hours, significantly improves, gives equal potent doses in the CSF level versus a IV dose given intraoperatively. And this from the website shows that the plasma concentration after 2 hours after it's been given of an oral versus a IV concentration is about the same. And then even if they can't take oral for some reason at 3 hours, the rectal dose has the same plasma concentrations. You can go ahead and go to the next slide, please. So result in the end, we can use and affect perioperative cost, specifically with acetaminophen, by kind of teaching our patient population, and teaching other surgeons that we can use acetaminophen oral in the perioperative period and have the same kind of patient outcome with this multimodal approach instead of using IV acetaminophen and significantly decrease costs to both the hospital and our patients. And I think it's at our next slide. So, I apologize for the dog acting up in the background.
Not a problem.
I have a question. I'm sorry, Wesley, do you have more slides or that was it?
I think that was it.
Okay. Yeah, so I have a question. So that graph that you were showing, it seems like after 3 hours, the IV Tylenol and the PO Tylenol doesn't have any significant difference. But it definitely shows that in the initial that 1 to 3 hour, IV Tylenol does have higher bioavailability and
So
higher.
Oops, sorry, go ahead.
No, that's what I was trying to figure out. That's what it looked like. It had higher concentration after the IV dose.
So that was
Is that right?
specifically from the website, and it's showing you that's what they were trying to say was in the first 2 hours you have a higher plasma concentration. That's also 1 gram being given up front. If you used it perioperatively, the past 24 hours, put them on a acetaminophen regimen, they would have significantly higher plasma concentrations by the time they went to surgery. I couldn't find that information out there. But the CSF levels and patient outcomes in the research show that there is really no difference between the two, oral versus IV. So that first 2 hours near post-op or from when you get the IV Tylenol versus if you give it oral beforehand doesn't really change the patient outcome in the end.
So I guess we technically will have to give it before, like not right before the surgery. Like sometimes people do like half an hour before or an hour before. So in that case, it may not be that beneficial. But what you're trying to say is like give it up front, maybe several hours, so patients can take it at home before coming to the operating room.
Right. Well, that's what the research has shown. And then there's also ERAS protocols. At our hospitals, we have them drink a little glucose drink. Some hospitals give the 1 gram of Tylenol, gabapentin, oral formations before you roll back to surgery. So kind of including it in that kind of aspect.
Thank you.
Good questions, good dialogue. Let's proceed on to section 4 of the pain medicine session. Our first one this evening is Alan Belangio on telemedicine, pain-free or painful, the use of telemedicine in pain management during the COVID era and beyond.
Thank you, Dr. Nossaman.
Yes.
Can we get the slides up?
Slides are not up?
Yeah, I don't know. Are they up for you guys?
No.
Yeah, they're not up. I don't see them. Okay, there we go. All right, thank you. Hi, everyone. My name is Alan Boyenchu. I'm a 4th year UQ Oshner student. So today I'll be presenting a study we have ongoing at Baptist Pain Management. This is a study in collaboration with Drs. Rahi, Dr. Gergis, as well as several residents and a couple of medical students, including myself. Next slide, please. So before I tell you about the study itself, just a little bit of background on chronic pain and telemedicine. So we define telemedicine as delivery of healthcare through virtual means, whether that be audio or video communication or both. So telemedicine has become a tremendous resource in getting patients seen that would otherwise be unable to come to clinic. This is especially true during the ongoing pandemic. And more specifically with chronic pain patients, this can be very beneficial in terms of getting them seen. So a lot of issues are pretty specific to chronic pain patients. This includes disability, stigma of their condition, and geographic limitations, which has also now obviously been exacerbated by COVID. So there have actually been a few studies that examine telemedicine and its impact on chronic pain patients. And some of these early studies have shown that telemedicine in these patients is not only feasible, but cost saving to these patients actually and the providers. And this is especially true in some more of the rural regions of our country. Next slide, please. So onto our study. This is a prospective study of patients who had 1 or more telemedicine visits with Oshner's Pain Management Group. We were looking at visits between March and July of 2020, right around the height of the pandemic. So we queried Epic and came up with a list of about 2,300 patients, a little over 2,300 patients. And we sent survey questionnaires to these patients 3 times through the Oshner patient portal. And we're trying to collect a few data points from these patients. Namely, we want to know what is their level of satisfaction with telemedicine? Do they have any specific concerns or experienced any specific benefits with telemedicine as opposed to in-person visits? Any visit outcomes such as changing of medications or procedures scheduled? And was their visit preferred to an in-person visit? So all the patient data was de-identified. We had very little exclusion criteria. We wanted patients that are over the age of 18 and fit within our 4 to 5 month window. And obviously they have to agree to participation. Next slide, please. So out of our initial pool of patients, we were able to send just over 2,000 through the patient portal. As of November 3rd, only 246 have completed the survey. However, we are continually getting responses and we're hoping this response rate increases. But so far we've analyzed patient responses according to age, race, education level, travel distance to clinic, any physical or functional limitations, their income level, and their competency with using technology. Next slide, please. So I have some preliminary results here. These are just a few data points that I have time to talk about today. So far, we've noticed that the majority of respondents, just above 70%, have been very satisfied with the telemedicine visits. The majority of patients either preferred telemedicine or listed no preference, and only about 30% preferred in-person visits. And secondly, we've noticed a trend of preference towards telemedicine in younger patients. However, satisfaction was pretty similar no matter what age they were. And then you can see in the top right here, patients with physical or functional limitations, basically anything that made it difficult for them to attend in-person visits. These patients overwhelmingly preferred telemedicine visits and were very satisfied in doing so. And then finally, we can see that travel distance definitely played a role in satisfaction. And that level of satisfaction and preference seem to correlate with how far the patient is from the provider, which makes sense if you think about it. So these are just some of the data points. We've also looked at race, education, race, education, travel, limitations, income, technology. So there were several others that I don't have time to go into today, but these are just a few. Next slide, please. So this is just some of what we've gathered so far in our study. I'm excited to see what's to come as we continue to get more responses. We're continuously getting them day to day. And we're hoping to get a better idea of patient satisfaction during these visits. We plan to compare satisfaction rates between audio, video, and both. And we want to see which patients are willing to continue these visits even after the pandemic is over. So previous studies of telemedicine have mostly neglected chronic pain patients, and there were several flaws with some of these early studies, such as small sample sizes, examination. They didn't examine satisfaction rates. They didn't really delve into costs, demographics, or treatment outcomes. So ideally, we'd like to address some of these gaps and gauge just how useful telemedicine can be in the chronic pain world. Thank you.
All right, this paper's up for discussion.
Hey, Ellen, I have a quick question for you. Was there a point distance-wise when patients preferred telemedicine instead of in-person? I couldn't read if there was one on the slide.
Sure, let me actually, if we can go back to that slide, actually. No. Okay, well, so basically we divided it into 10 miles or less, 10 to 30 miles, or 30 miles or more. And in terms of satisfaction, it seemed like the majority of patients, the majority of patients were satisfied no matter how far they were. So there really wasn't like a cutoff point in terms of distance to where it jumped up significantly.
Okay, great, thanks. Just curious.
Mm-hmm.
Though I applaud the use of survey instruments, what's the inherent danger when you have such a small sample size?
Well, that's the problem we've kind of run into so far, is that we're kind of trying to address, is the fact that a lot of these patients do get these surveys. They try not to, they don't really pay attention to what some of their answers. And then it doesn't really paint a great picture of the overall patient population.
Yes.
In terms of, small sample size.
Back in the day when nitrous oxide was alleged to cause an increase in birth defects or abortion in dental hygienists using nitrous oxide. It was due to an incomplete survey in which only the women that actually had the issue responded to the survey, whereas the vast majority of the women who didn't have the issue, spontaneous abortion and the like, just tossed the survey into the circular file. It misled for 20 years.
Yeah, so I was gonna just make a comment and ask a question as well. And I absolutely agree with what Dr. Nosman just said. I'm personally interested in chronic pain, so this topic is very dear to me. And great job on this study. Although you have obviously, I think around like 10% response rate. So obviously that's not the representative sample for the entire population. And then at the same time, I would think it would be slightly biased because it depends on what kind of intervention was being offered during these telemedicine visits. Most of these patients, I would assume, were just seeking to renew a script as compared to having a pain procedure, which obviously you can't do online. And I don't even know like how we would do that. So, and the other thing is like, obviously medicine is changing. There's a lot of room for telemedicine and primary care physician's office. But if we are going to in this direction, what are we going to do with the billing component of that? How are we going to bill those? And I would like to know how Osher is doing that and what kind of platform are they using for their telemedicine visit?
And that's another dimension that we've kind of looked at in our study that I didn't have time to go into. We did also survey patients to ask them what they were actually going to these visits for, whether they were getting procedures scheduled or a medication started or restarted. So there's still a little bit more to kind of flesh out in this study. It's just in its very infancy. So we hope to get some of those questions answered.
Sure. Thank you. Keep up the good work.
Thank you.
Yes. Proceeding on to our next pain medicine presentation, comparison of spinal cord stimulator efficacy and explant rates in multiple outpatient clinics by student Dr. Carmel Alimai. Please.
Hi, thank you, Dr. Nosman. Sorry, can you guys hear me?
Yes.
Okay, great. So I work over here at Ochsner Baptist as a clinical research coordinator, and I was working on this study with Dr. Gerges, Dr. Scheiban, Dr. John, Dr. Shetty, Darby Larson, Aaron, and Dr. Shragi. So pretty much, you can go to the next slide. Thank you. So pretty much our study was looking into sort of why do certain spinal cord stimulators work better for certain patients versus others. So spinal cord stimulation works by having electric stimulation delivered over the spinal cord, overlying pain areas, and either blocking them out completely or overlying the pain areas with paresthesias. So we decided to use also a survey model for this, and our study questions were which devices were most effective and had the lowest explant rate, and were there any patient or pain characteristics that led to a greater relief with their spinal cord stimulator. Next slide, please. So what we did was we queried our electronic health record system, EPIC, for patients that had a trial or an implant between January 2012 or December 2019 at any Ochsner pain medicine clinic. So we split up these patients and we called or emailed them and sent them our survey questionnaire. So our survey pretty much looked into, were they satisfied with their device? Were they actively using their device? Did they feel like they had long-term pain relief? And ultimately just, was it efficient? Was it effective for them? So we also had other questions on how did they feel about recharging their device? Did they feel like they knew how to work it well? And were they getting follow-up care that they needed in order to operate their device as well? So patients that were saying it doesn't work, were they going to their field technician or their pain medicine clinic and telling them that? So we did this with the surveys, and we plan on continuing on in this study and using retrospective chart reviews to collect any pain history, like what were the indications for getting spinal cord stimulator, demographics, and levels of pain relief through pain scores, PDI, and their total opioid usage. Next slide, please. So if you look at our results, we also had like a smaller sample size, but we had most patients were generally satisfied and would recommend this treatment for other patients with similar pain. And if you look at the number of patients who were explanted or not using their device, so for Abbott, we had 11 out of 21 patients who either explanted or weren't using their device, said that they just didn't have any improvement in chronic pain. For Boston Scientific, it was 3 out of 14. And for Nevro, we had 2 out of 8. And we had a few other indicators listed there for reasons that they were either explanted or not using their device, including battery death, infection, need for MRI, and with the additional pain or discomfort, we have noticed that that could be related to, any weight loss that could happen, and then they could have pain at their IPG site. So there are a few different factors that go into why a patient explanted their device or why they're not using their device. And we hope that further chart reviews will kind of like clear up why exactly these patients felt that they weren't getting what they needed from their device. Next slide, please. Next slide, please. Thank you. So our plans are, like I've said before, we are going to keep doing chart analysis. So we're going to look at patients that have had a trial or an implant. So patients with a trial, we're going to look at why did the trial fail? What pain characteristics did they have? What indicators did they have for needed a spinal cord stimulator? And same with the patients with the implant. And we're going to go even further to look at maybe demographics, any social determinants of health, see if there's any correlation between a positive or a negative experience. So another limitation we have is that we have a small sample size, and that could lead to bias. So any bias that we have with the study could be, we call patients and some of them decline to participate. That could be that they're really unhappy or they just don't think about their pain anymore. It could go really either way. So in order to get a real gauge of long-term outcomes, we plan on enrolling these patients into a prospective version of the study. So when they're getting their, when they're doing their trial and when they're getting their implant, we're going to consent them and ask if they would like to be part of this, and it'd be a registry. And we would go on to send them questionnaires about their pain relief, satisfaction periodically, and have them answer them. Okay, and that's all for me. Do you all have any questions?
Discussion. Well, I appreciate that you're taking the time and effort to investigate this. As you know, chronic pain is a major issue in our patient population in the US of A. I do like the idea of the prospective nature, and maybe like a phone app, a smartphone app could be written in which friendly reminders could be triggered so that the patient could participate their activities of daily living, kind of get a gauge of what they're doing, and also the pain skill scores that they may have, and what other necessary components of your study would be required to elicit the benefits of this type of medical therapy.
Yeah, that's a great idea. I think as of now, we're planning on using RedCap, and when we get patients to sign up, we can automatically send them email surveys, but a phone app would be much more efficient and would probably have patients more likely to respond.
Okay, thank you. Proceeding on to our third presentation in pain. It's a big word. Onabotulism toxin A versus anti-CGRP antibody therapy for the treatment of chronic migraines by Darby Larson.
Yes, thank you very much for the introduction. Onabotulinum toxin is a tongue twister that I practiced all morning. But this study is looking at a comparison between onabotulinum toxin A versus anti-calcitonin gene-related peptide antibodies therapy for chronic migraine management. Next slide, please. So there have been historic breakthroughs in migraine management that have shown the benefit of neurotoxin onabotulinum toxin A, and more recently, anti-CGRP antibodies for the treatment of migraines. Based on the current literature, there's evidence that intramuscular injections of both of these could provide pain relief for chronic migraine headaches. The efficacy of the neurotoxin and the anti-CGRP mAb have been studied separately, but there are very few studies comparing them directly head to head. So the goal of this study is to perform a retrospective chart review evaluating the effectiveness of the neurotoxin versus the monoclonal antibody. And for the purposes of this study, we used Erinumab for chronic pain or chronic migraine treatment. Next slide, please. So as I said before, this study performed a retrospective chart review of 200 patients at Ochsner Pain Management with IRB approval. So the criteria for the chart review was patients who have received the neurotoxin treatment for migraines between April 2016 and September 2018, or they had received the Erinumab treatment for migraines from May 2018 to September 2019. From the charts, we obtained pain scores which were indicative by the numerical pain rating scale, the NRPS, and then they were analyzed before and after the initiation of treatment with either the neurotoxin or the mAb therapy. Next slide, please. So looking at table 1 on the right, the neurotoxin group, the mean pain score prior to the procedure was a 4.65 for the pain score. And after the procedure, it had dropped to 3.14, which produced a mean change of a decrease in 1 pain score point. Meanwhile, the pain score for the monoclonal antibody group prior to the therapy was 5.67, which then dropped to 2.21, which was a median drop in 3 points. So the average reduction in the pain scores for the neurotoxin was 28.8% compared to 63.5% of all patients who received the treatments for the monoclonal antibody therapy. It is important to note too that 55% of the patients who received the monoclonal antibody therapy had a reduction in pain greater than 50%, compared to only 31% of patients who had received the onabotulinum toxin therapy. So only 31% received relief greater than 50%. The majority of patients in both treatment groups did have reduced pain scores, so the study does support the current literature stating that both neurotoxin and monoclonal antibody therapies do relieve chronic migraine headaches. Next slide, please. So the length of the pain relief, also comparing between the two, was also not statistically significant, but it could potentially be clinically significant for clinical practices. The monoclonal antibody therapy may be recommended to patients who have chronic migraines refractory to conservative treatment and who fail to improve with the neurotoxin therapy. Moving forward, this does suggest that there should be further research to compare the two, the neurotoxin and the anti-CGRP mAb drugs, such as galcanezumab and fremanezumab. That's it for me.
This paper's up for discussion. You bring up a very important point in your conclusion slide that you have a finding that, although not statistically significant, could be clinically significant. And that's what is important to distinguish, in that we want to kind of evolve away from using what is known as frequentist statistics. That's the chi-square and the t-test, and drive towards p-values of a certain cut point, whereas where risk differences, which was presented earlier, actually shows a measure of effect. And you found in this paper, in this study, a clinically significant effect. And that's good.
Correct. And it's important for clinical practices as well, like you said, to develop a good algorithm for the treatment for the benefit of the patient.
Yes.
I had a quick question as well.
Please.
I was just wondering for the Botox patients, was it like a certain amount of treatments that y'all had looked at to compare that to the monoclonals?
So I believe it was only one index treatment that was used to compare to the monoclonal antibody. So it was just based off one treatment for the pain score prior to that treatment and then after that treatment.
Thanks.
Thank you. Alan again presents the next poster presentation, trigeminal nerve block of the head, neck, cancer patient, a case of metastasis is attributed to procedural complications.
All right, thank you, Dr. Nossaman. So this is a case we saw at the Baptist Pain Clinic. It was a pretty interesting case. So before, next slide, please. So before I tell you about the case itself, just a little bit of background on trigeminal neuralgia. So as many of you know, this is a rare disorder. It can be severely painful. It's characterized by its distribution along the trigeminal nerve. And although it is rare, it is at the same time one of the most common causes of facial pain in patients over the age of 50. It's usually associated with underlying neuromuscular compression. And the way we usually treat it is with a trial of carbamazepine initially. And this helps most patients, but for greater than 25% of these patients, it's just not enough. So they either have inadequate relief or get intolerable side effects from that medication. And a lot of these patients do end up benefiting from trigeminal nerve blocks, which is what we ended up doing for this patient. Although this comes with its own set of complications, including vision loss, carotid injury, dysesthesias, hematomas, motor deficits, and even intracranial bleeds, although these are rare. Next slide, please. So our patient was a 73-year-old Caucasian male, long history of tobacco use. He was diagnosed with laryngeal cancer after presenting with left throat and ear pain to his ENT. His ENT ran some imaging and biopsies, diagnosed him with supraglottic squamous cell carcinoma. So for this, he received neoadjuvant chemo, as well as radiation and salvage therapy with left neck dissection and skin grafting. So after his surgery, he continued to receive Keytruda infusions for 3 weeks. He was doing well for a while, but reported left trigeminal nerve pain several months later. And that began after his debulking, but progressively became worse. So this is when he came to see pain management for the first time. His pain was uncontrolled on medications. He was deemed a candidate for trigeminal nerve block and possible radiofrequency ablation in the future. Next slide, please. So he underwent the nerve block via fluoroscopy that same week and tolerated the procedure well. There were no issues. However, a week later, he presented to his local ED with oral swelling. He had severe tongue swelling and was unable to swallow for the prior 4 days. And he was with his wife, who had stated that his speech had become mumbled. She had a hard time understanding him. He denied any facial droop, but reported oral numbness and tingling. So his wife had also noted that he had been vomiting up some mucus over the past several days. They did a physical exam. He was afebrile. His vital signs were stable. He had some mild tongue swelling and a garbled voice. And he was also noted to have yellow mucus in his posterior retropharyngeal space. So at this point, they did some labs. He showed a leukocytosis to 18, hyponatremia 128, and his inflammatory markers were also elevated. So they went ahead and imaged him. They did a CT scan of the soft tissues of his neck. And that showed some thickening at the level of his epiglottis and aryepiglottic fold. They treated him with clindamycin and referred him back to his ENT and oncologist. Next slide, please. So because of the proximity and time between the nerve block and his ED visit, there was some thought that these symptoms could be due to the nerve block. He returned to our clinic and was evaluated. On exam, we noted that he had bilateral tongue and right-sided lateral gaze paralysis, which was contralateral to the procedure side. So it was determined at that point that this was unlikely to be due to the block. And I'll talk about why in a minute. So he was referred for MRI of the neck just to get a better picture of what was going on at that point. On MRI, he was found to have an enhancing lesion at the left skull base extending to his larynx. And this was concerning for cancer recurrence given his history. So oncology concurred, the patient was informed of the diagnosis, and there was a conversation about end-of-life care, and he was then referred to hospice. Next slide. So as mentioned before, complications with these blocks are exceedingly rare. They're done all the time with almost no complications to most patients. They're usually things like loss of consciousness, dysesthesias, hematomas, and temporary sensory loss. Out of all of these, the temporary sensory loss is by far the most common. That happens in up to 50% of patients, but that's a transient side effect. The technique itself poses little risk of block or injury to other cranial nerves, especially in this patient who appear to be having bilateral hypoglossal palsy and contralateral abducens palsy. So if you remember your neuroanatomy, this would indicate a bilateral hypoglossal nerve palsy and contralateral abducens nerve pathology given his physical exam, which would be highly unlikely to result from a trigeminal nerve block. So importantly, the hypoglossal nerve exits the cranial cavity via the hypoglossal canal, and the abducens nerve exits via the superior orbital fissure. Neither of these were close to the foraminal valley where the block occurred. So in cases like this, we just have to remember it's important to have a fundamental knowledge of your neuroanatomy, as well as understand any possible procedure complications you can encounter when undergoing these procedures. And knowing these two things, you can make an accurate diagnosis most of the time. All right, thank you.
All right, this case is up for discussion. Thank you for that extensive workup. Regretfully, the specialty has been blamed for a lot in the 40 years that I've been practicing, which with a thorough investigation, we find out that the specialty is not the etiology of the wayward events.
Yeah. Absolutely, and I think once we were able to get some eyes on the patient and do our own investigations, it was pretty apparent that it had nothing to do with the block.
Yes, yeah. Carmel returns again, presenting evaluation of long-term outcomes of kyphoplasty in multiple outpatient clinics.
Hello. Okay, so I worked on this study with Dr. Shragi, Dr. John, Dr. Shetty, Darby Larson, and Dr. Gertis. We can go on to the next slide, please. So this study is meant to kind of get a gauge of what the long-term outcomes of balloon kyphoplasty is for patients. So balloon kyphoplasties are used to treat vertebral compression fractures, which in osteoporotic patients can happen with very minimal or no trauma, but otherwise can occur due to maybe mets in the spine or severe trauma. So in the past, they have been treated with less than 50% loss of body height. They've been treated with bed rest, narcotic pain medication, other bracing modalities. And this has been known to cause further spinal deformities and worsen, like including kyphosis, worsening loss of height, and also decreased lung capacity, decreased mobility, and general disability. So with a balloon kyphoplasty, you insert an inflatable balloon tamp into the fractured vertebra, and after inflating it, you can introduce a bone cement. This helps to ensure that the spine is correctly aligned and there's a full restoration of vertebral body height. our question was, do kyphoplasties have long-term benefits for patients with vertebral compression fractures? And additionally, which characteristics of either the fracture or the patient ultimately influences outcomes? Next slide, please. So for this study, we did a retrospective chart review of patients treated with a balloon kyphoplasty at any Ochsner pain medicine clinic between January 2017 and March 2019. We queried our electronic health record system, EPIC, for these patients and additionally pulled data on pre and post pain scores, pain disability index scores, morphine equivalent dosages. We additionally looked at medical history, including do they have osteoporosis, and also we went on to look at the cause of fracture. Was it traumatic? Was it non-traumatic? The chronicity of the fracture, so the time between fracture onset and the procedure. So for that, we went into acute, which was less than 6 weeks in between those two things, subacute 6 to 12 weeks, and chronic greater than 12 weeks. Additionally, we looked at the severity of the fracture. So we used a semi-qualitative analysis to look at that. So grade 0 would be completely normal, no loss of body height. Grade 1 is 20 to 25% reduction of vertebral body height. Grade 2 would be 25 to 40%, and grade 3 would be greater than 40% loss of vertebral body height. Next slide, please. So I didn't have time to pull all of our results into this, so we're just going to look at the patients with or without osteoporosis. So as you can see for, in the first graph, let's go, that would be the pain score. In the pre-op, we had an average pain score of about 8, and within 3 months of post-op, it went down to around 5. And then when you go on to 6 months, the patients without osteoporosis had even more distinct decrease in their pain level, and the patients with osteoporosis maybe rose up a little bit. So if you look at the PDI, kind of the same general, just there, went down significantly after the operation, and then went down a little bit more 6 months, and then we kind of get back up there. And so for morphine equivalent dose here, we don't have a hugely significant change between pre-op and post-op, but that could also just be, we were looking at whether or not these medications were given to the patient, and we don't necessarily have information on how frequently they took it and how often they needed to take it. Next slide, please. So if we were looking at the graphs before, we could see that after about 6 months, the pain scores and the PDI scores rose dramatically. So this would be the limitation with our study. If we're looking at retrospective analysis here, we're only able to get the data that we find in EPIC. So if these patients are continuously coming back to pain medicine after 3 years after their procedure, they probably have some other pain, or they never had any relief. So this kind of makes our data a little bit biased. And so if you look over here, visit 5 would be 3 years after the procedure. Initially, we would start with about 175 patients, and then once we get to visit 5, we're at 3 or 5. Visit 4, still not that many patients. We lose over a third of our patient population after the 6-month visit. So with this study, along with the spinal cord stimulator study, we had planned to do a prospective registry, kind of a similar idea. We have patients enroll as they get their procedure, and then we periodically would ask them about their pain scores. Did they have any recent injuries that would maybe contribute and stuff like that, just to get a gauge long-term how well is the kyphoplasty working. And that would be all for me. Do you all have any questions?
Well, I have one. As the therapy, the effect of the therapy waned, was there repeat imaging done to see did the structure, whether structural failure of the kyphoplasty, or were there associated vertebra above and below that were starting to also collapse?
Whether or not patients had subsequent fractures after this this procedure, because it's known that, you know, maybe with the cement there could be extra strain on the spine, and that could cause other fractures. And I didn't really have time to go into that here today, but we do plan on looking into that to see if that is a contributor to more significant pain later on. As for post-imaging, we did not look into that. We did not have enough data to kind of look into whether or not that would help. That would be like significant for pain relief. We had initially planned on looking at pre and post vertebral body height, but it was just a little too, it wasn't written down in the radiology notes. So it would be going through each of these charts and personally measuring, and we thought that there would be a little bit too much room for error there.
Okay. All right. Well, thank you. We'll proceed on to our next presentation, the retrospective outcome analysis of cooled radiofrequency ablation of the genicular nerves for the treatment of chronic knee pain. Darby Larson.
Yes, thank you very much. This one's a little bit easier to say than onabotulinum. Yes, we did a retrospective analysis of cooled RFA of the genicular nerves for the treatment of chronic knee pain. That was performed at Ochsner Baptist. So cooled radiofrequency ablation, CRFA, is a well-established method for delivering lesions into nervous tissue to reduce pain. There's been significant literature that has noted the clinical outcomes of CRFA in anatomical locations already, including sacroiliac joints for indications such as sacroiliitis and the lumbar spinal disc. There's also been promising results from studies investigating the effects of CRFA when used for genicular neurotomy procedures to reduce knee pain from indications such as osteoarthritis. The degree of pain relief from conventional non-cooled radiofrequency ablation may be less than those who have received cooled RFA. So this retrospective chart review looks to follow the outcomes of patients treated with the CRFA to evaluate its effectiveness for treating chronic knee pain. Next slide, please. For this retrospective chart review, we queried in EPIC and looked at 205 patients who had undergone cooled radiofrequency ablation at the multi-site pain practice throughout Ochsner between December 5th, 2017 and September 4th, 2019. The primary outcome for the study was the change of pain disability index scores prior and post-procedure, followed by secondary outcomes of change in patient-reported pain scores measured through the numerical pain rating scale, and the change of opioid consumption, which was measured by the morphine equivalent dose. So out of the 205 patients, only 104 had PDI scores in their chart before and after the index treatment. So this study was limited to only those 104 patients who ranged in age from 21 to 89 years old, 38 of which were male and 66 female. Next slide, please. So we're going to start by looking at figure 3 on the right, which is the demonstration of PDI score change pre and post procedure. So the mean PDI before the genicular nerve block, which preceded the CRFA as part of the treatment regimen, was 38.7. And that dropped to a mean PDI after the radiofrequency ablation to 26.5. So 67.38% of patients had a decrease in their PDI scores, while 27.9% had no change, and 4.81% actually had an increase in their PDI score. So that was statistically significant for patients reducing their pain. Looking at figure 2 on the bottom left, the mean NPRS score prior to the treatments were 6.98, which dropped to an average of 4.18, which was also statistically significant, with 49% of patients having a pain reduction of 2.25 points And the next largest group, 17.3% of the patients, actually had a reduction of 0.75 points. It is important to note that almost all patients did have a reduction in pain. Finally, looking at figure 1 on the top left, when comparing the morphine equivalent dose prior and post-procedure, 37.5% of patients were not on any opioid medication at any time during the study, and morphine equivalent doses did not change for the majority of patients, 80.77%, while the MED actually decreased for 13.46% of patients and increased for 5.77%. Due to the vast amount of patients having no change in opioid consumption, there's no significant difference for the morphine equivalence dose before and after the CRFA therapy. Next slide, please. So after the CRFA, like I said, the mean PDI score was reduced by approximately 31.5%. However, 32.7% of patients had either no change or an increase in PDI scores. And this could be indicative of many patients having other sources of chronic pain besides knee pain, which also contribute to their PDI scores. So that that no change or an increase could be a result from the other types of pains that they have. The majority of patients did report a reduction in their overall pain levels. 50% had that pain score reduction of 2.25% or 2.25 points. So the results from the study do indicate that cooled radiofrequency ablation treatment does provide significant pain relief and reduces the disability caused by chronic knee pain in a patient's daily life, and therefore could be a good result for patients who fail conservative treatment. That's it.
This paper's up for discussion. What question, Darby, do you have in looking at all these data that says this is the new direction we need to go into? We need to be in this direction now in the treatment of this patient population.
That's an interesting question. So for this, I think moving forward, it would be important to see how different age groups react to the CRFA treatment, as well as what indication they're receiving it for, whether it's osteoarthritis or traumatic arthritis. And it's important to understand which groups do benefit the most from it to provide better treatment as well.
Okay, that'll work for me. Our next presentation in our pain medicine section is by Madison Boudreau, evaluating chronic use of opioids in COVID-19 survivors.
Hi, yes, our project is on evaluating chronic use of opioids in COVID-19 survivors, and here's a list of our contributing authors. Next slide, please. So just a bit of a background with regard to the opioid epidemic. Obviously, this is an ongoing problem in the United States, kind of towards the early 2000s, and has since progressed, as I'm sure many of us have seen in the news and in hospitals. Just to give some perspective, in the year 2000, there were about 43.8 million opioid prescriptions, and in just 10 years, in 2010, we have doubled that, more than doubled at 89.2 million opioid prescriptions. And as far as this study, we define chronic opioid use as use of opioids for 3 months or greater, and this is usually indicated in chronic pain conditions or chronic conditions in general. And as far as the COVID-19 pandemic, as we know, has been going on in this year, anecdotally, we have found that opioids are being used inpatient for COVID-19 patients for myofascial pain and general deconditioning when in the ICU for long admission stays. And another component to this with the COVID-19 pandemic is that recent studies have also shown an increase in illicit drug use. compared from post-pandemic to pre-pandemic. They saw a 32% rise in fentanyl use and a 12.5% rise in heroin use based off of urine drug screens in patients either with substance use disorder or considered to be high-risk substance use disorder. And these were not patients with prescriptions for these medications. Another thing to take into consideration in light of the pandemic is the increased psychological stress associated with these uncertain times, time off of work, the social distancing requirements, and the downtrending economy. So with these two things combined, we thought it would be a great idea to kind of investigate the use of opioids and whether chronic use is seen. Next slide, please. So as far as our objectives for this study, our primary one was to really determine the incidence of chronic opioid use following COVID-19 admission with inpatient opioid treatment given. And as far as our secondary outcomes, we just wanted to look at the general patient characteristics, so gender, age, as well as social determinants of health, because we were thinking this could potentially impact whether people were more likely to meet the criteria for chronic opioid use. We also wanted to look at comorbidities, medical and mental health, because these could play a factor in developing this chronic use. We also wanted to look at the Charlson comorbidity indices of these patients, and that predicts a 10-year survival for the patients based off of multiple comorbidities, as well as their age. We also wanted to get data on the opioid prescription type, as well as the equivalent dosing for each of the drug types. And we also wanted to look at telemedicine visits, particularly to see, especially in the time of COVID, whether this helped or increased the incidence of having chronic opioid use. If they were able to follow up, at least virtually, did they maybe have better management as far as kind of getting off the opioids. Next slide, please. So as far as the methods, this is a retrospective chart review of approximately 400 patients. We're still kind of fine-tuning our criteria, and we're using the Ochsner Health COVID-19 databases. Patients were followed for 90 days following discharge in order to assess for that criteria of chronic opioid use, the 3-month mark. So as far as our inclusion criteria, we wanted participants 18 or older, having a positive COVID test after March 1st, being hospitalized between March 1st through July 31st, again, to get that 3-month follow-up. Another one was that they were hospitalized within 30 days of the positive test. This could be before or after. And then the diagnosis codes that we were looking at were COVID-19 infection and COVID-19 pneumonia. At first, we had started looking at just COVID-19 pneumonia, but early on, when patients were coming in and we were chart checking, we saw that some providers had not specifically listed COVID-19 pneumonia, so we didn't want to miss this large chunk of patients. So we've added in, COVID-19 infection with the given keywords, as you can see listed there, more related to respiratory symptoms in particular. We also wanted them to have gotten opioid medication while hospitalized and have their stay longer than 1 day. As far as exclusion, it's pretty much what's not included in the inclusion, and the only additional thing was if any patients had death during the hospital stay, they were also excluded. And if there were multiple admissions of the patient, those were collapsed into one encounter, so they weren't counted twice. Next slide, please. So as mentioned, we're kind of fine-tuning the data now, but from where we're at in this particular cohort was about 467 patients total. And it appeared that 16% of those patients met the criteria for chronic use. And just looking at some of the characteristics in table 1, it appeared that females were more likely to develop that chronic use, 60.3%, compared to the males that did not, 45.5%. As far as the telemedicine visits, it appeared that more patients that had developed or met the criteria for chronic use were utilizing telemedicine visits, approximately 46.2% of them. and the majority were of one visit. So 19% had about one visit. And that's in table 2. And the last table on the right there, table 3, is just a list of the common opioids that we had encountered for the outpatient prescriptions, with 50% being hydrocodone and tramadol, oxycodone, and hydromorphone also being frequently prescribed. So we're still kind of in the beginning of this research project and still kind of fine-tuning the inclusion criteria. So we're excited to see what we find.
So I have a question, and I mean, you guys are trying to find some interesting data, but is there any documented evidence for there's? Sorry, my kids are screaming in the back. Evidence for increased opioid consumption in COVID patients?
We're still trying to find like COVID specific opioid use because it's more been like an anecdotal thing as mentioned. So I wouldn't say that we've come across specific increased use, no.
But why? So even from anecdotal standpoint, like why do you think COVID patients would have higher opioid consumption rate? I think all the data that you have presented so far, it points to the normal factors that you will expect in any kind of patients with increased opioid consumption.
Yeah, I think it more had to do with opioid, or we wanted to see if there were like opioid naive patients to where they weren't on any prior opioids and, you know, strictly used in the inpatient setting for any type of like deconditioning or myofascial pain just associated with the COVID-19 syndrome, and whether or not they would continue to use the opioids in a chronic setting, I think.
Okay, and I just wanted to point out one more thing over here, just like I think one of the data point you showed that telemedicine visit among the patients who are outpatient user. Am I reading it right? The ones who were using it was 36, and when the ones who were not using it, what, 77?
I'm not sure where you see the,
Table 2.
oh yeah. So I think, oh yeah, I think you're right with the not using it, and then so the group was, no, I'm confused. 46% had used the telemedicine visit in the group if they had the outpatient opioids.
Okay, so there's and the point that I was trying to make, and it kind of refers back to what Alan was presenting earlier. Again, this is an anecdotal thing. Obviously, we have to look into it more, but I would assume that most of the patients who want to do telemedicine visit or quote unquote are more I would say contended with that visit is who are just looking for prescriptions, and they're looking for prescription refill. So obviously you're going to find higher satisfaction rate among those patients because they don't want to be in the clinic, to be in that situation where they have to talk face to face with the physician.
Yes,
But
yes,
interesting
I understand what
findings.
you mean. And them having to like get the prescription refilled, it would make sense why they would want to utilize the telemedicine visits compared to those that weren't continuing to refill those prescriptions.
Absolutely. Thank you.
Thanks.
All right. Madison closes out our pain medicine section. We'll now go to our pediatric anesthesia section with Jacob Boudreau presenting the 2 papers. The first being pulmonary overcirculation from dural AV fistula in a neonate.
All right, thank you very much. Before I start, I just want to say thank you to the LSA for putting this on. I really appreciate it. Had some great presentations tonight, and I'm glad to get to contribute. Next slide, please. So pediatric intracranial arteriovenous shunts are rare presentations that comprise pial arteriovenous malformations, pial and dural arteriovenous fistulae, and vein of Galen malformations. The severity is associated with degree of shunting and ranges from benign to cardiopulmonary compromise and congestive cardiac failure. We present a neonate evaluated for tachypnea and pulmonary hypertension caused by a dural AVF that required percutaneous intervention under anesthesia. Next slide, please. For this patient, she was a 12-day-old neonate who was evaluated with tachypnea, and on 2D echo, it was demonstrated that she had severe right ventricular hypertension, atrial septal defect with right to left shunting, pulmonary hypertension at 85 millimeters of mercury, and a dilated right ventricle and superior vena cava. The patient was then admitted to hospital for suspected vein of Galen malformation and started on inhaled nitric oxide, sildenafil, and high flow oxygen for potential persistent pulmonary hypertension of the newborn. So a little background on these two different pathologies. A vein of Galen malformation is a type of rare blood vessel abnormality inside the brain. In these malformations, the misshapen arteries in the brain connect directly with veins instead of connecting with capillaries, which helps slow down the blood flow. This causes a rush of high pressure into the veins, and persistent pulmonary hypertension of the newborn is defined as failure of the normal circulatory transition that occurs after birth. It's a syndrome characterized by marked pulmonary hypertension that causes hypoxemia secondary to right to left shunting of blood at either the foramen ovale, the ductus arteriosus, or both. Now, I don't know if my slide will play, but if you click on those two, the MRA and the MRI, they should start to play a movie. If not, it's okay. Okay, I probably got lost when I sent it over, but I assure you they're really great MRAs and MRIs once they're played. So for both of those, we saw right frontal lobe mass effect and right middle craniofossa DAVF. So for this case, it was revealed that the DAVF acted as a high flow left to right shunt that led to high output cardiac failure in this neonate. It was then decided to wean the nitric oxide, sildenafil, and supplementary oxygen to avoid damage to the pulmonary vasculature from pulmonary overcirculation. The patient was then diuresed with chlorothiazide and furosemide, which improved right ventricular function and lowered the pressure in the pulmonary artery. It was then elected to undertake surgical management via percutaneous shunt embolization. Next, please. As for our anesthetic management of this case, we used ketamine for induction due to better hemodynamic stability. We had an arterial line placed for monitoring systolic blood pressure during the case and a central line placed for venous access. We had two respiratory goals for this case. The first one was maintaining a mildly elevated CO2 level for cerebral vasodilation to facilitate surgical access. And the second one was we wanted to keep the pulmonary vasculature resistance elevated. That way we can reduce pulmonary overcirculation. It took 9 attempts, but the procedure was successfully completed. And afterward, fluids were strictly maintained strict maintenance of the fluids, only limiting to maintenance fluids and fluid flushes during medication administration. Following a successful procedure, the patient remained intubated and sedated postoperatively with Precedex and fentanyl. Next. So pediatric DAVFs, these are very rare and have an aggressive clinical course compared to their adult presentations, with mortality seen in this patient population at about 25%. For neonatal and pediatric presentations, these are primarily going to consist of cardiopulmonary symptoms of congestive heart failure and respiratory disease. What's most unique about this presentation was the volume of blood that was shunted, which caused such a high output congestive cardiac failure. This is typically seen in a vein of Galen malformation, where about 25% of total neonate cardiac output may pass through the fistula. So the effects of high flow, low pressure shunting DAVFs on neonatal cardiopulmonary system and the risk of general anesthesia for an ill neonate poses significant challenges for anesthetic management. And understanding the physiological effects of these malformations is critical for not only intraoperative management, but postoperative success. Thank you.
This paper's up for discussion. All right, Jacob, why don't we go to our next presentation, consecutive cardiac and renal transplantation in a pediatric patient at first for the Ochsner Medical Center.
All right, let's do it. Can you guys see the slides? Because I can't see them on my end. There you go. Thank you. So as the title said, this was another case report that was done with Dr. Cologne here at Ochsner. Next, please. So simultaneous cardiac and renal transplantation is an effective surgical strategy for pediatric patients with combined cardiac and renal failure. The complex pathophysiological relationship between both organs is multifactorial in origin and may lead to or be the result of primary dysfunction in either organ system. Cardiorenal syndrome refers to a complex pathophysiological state in which heart and kidney dysfunction coexist, and the primary failing organ, as I said, can be either the heart or the kidney. Although there is a robust amount of adult literature for CRS, in pediatric patients, the literature is very limited. However, CRS is increasingly being recognized as an impactful clinical problem that can have important implications regarding the need for treatment and prognosis. Although wide acceptance of a unified definition of CRS is lacking, there is a general consensus that exists that CRS can either be primarily caused by the cardiac disease with secondary effects on the kidney or vice versa, as well as secondary to other systemic conditions. So for our patient with a history of organ transplantation, CRS may actually be due to low cardiac output, nephrotoxicity of immunosuppressants, or ischemic renal hypoperfusion. Next, please. So like I said, there are limited reports that have been made regarding simultaneous cardiac and renal transplantation. We report the medical history, anesthetic management, and post-operative outcome for a 13-year-old boy with a past medical history of orthotopic cardiac transplantation with multiple episodes of rejection and acute kidney injury requiring dialysis, who received consecutive cardiac and renal transplantations, which to our knowledge is the first that happened at Ochsner Medical Center here in New Orleans. Our patient is a 13-year-old boy with a history of Berlin cardiac placement and heart transplantation due to dilated cardiomyopathy, which was undertaken at Texas Children's in April of 2019. I'm sorry, in April 2009. He has a long history of non-compliance and chronic renal failure, along with both antibody-mediated and cellular rejection. He has since been placed in his sister's care as legal caregiver, and he was most recently treated for heart failure and suspected antibody-mediated rejection in May of this year. In August, he was taken for VAD support with the Berlin heart. Next, please. So a bit how he presented. He was admitted on September 15th for emesis, moderate ventricular dysfunction, and acute on chronic renal failure with low urine output. A cardiac catheterization 2 weeks later showed biventricular systolic and diastolic heart failure, secondary to antibody-mediated rejection. As I mentioned, he was status post-Berlin BiVADs for worsening cardiac output and was relisted for a heart transplant. He was on CRRT for his AKI due to cardiorenal syndrome, and with a lack of improvement in renal function, the decision was made to list him for a renal transplantation as well. The apheresis team conducted DSA desensitization prior to having the combined heart-kidney transplant, which was scheduled 2 days later. The plan was to do the renal transplantation in the afternoon and the cardiac transplant after midnight. So for our young man, we had arterial and central lines replaced for vascular access and monitoring, and a TEE was used throughout the cardiac transplant. There were no apparent anesthetic complications throughout the first case. The kidney initially showed pink color with good perfusion, then appeared to slightly become a bit of sluggish due to a slightly lower blood pressure, with the kidney becoming soft. Verapamil and lidocaine were used to augment the flow to the kidney. For the cardiac transplantation, anesthetically, it was also unremarkable. The patient had about a total ischemic time of about 125 minutes with minimal blood loss throughout the procedure. Afterward, he was extubated, moved to PACU, and then taken to cardiovascular ICU in a critical but stable condition. He was given multimodal analgesia, IV opioids PRN for pain control post-operatively. Next slide, please. So just to sum it up a bit, consecutive cardiac and renal transplantations in a pediatric patient have yet to be undertaken to our knowledge at Ochsner Medical Center. The cardiorenal access is of significant importance to patients, not only adult patients, but also pediatric patients in both acute and chronic conditions. Early recognition of either myocardial or kidney dysfunction allows for appropriate consultation and effective multidisciplinary care that can favor the outcome for the patient. A bit of an update on him: 3 months later, the patient remains currently without evidence of rejection. Although his hospital stay was complicated by multiple ulcers that he acquired over several weeks inpatient, he now attends office visits fortnightly with better medical adherence now that he's under his sister's care. Additionally, he also has a new diagnosis of diabetes, which did require hospitalization last month in October. So for our patient, his extensive medical history and increased risk of postoperative morbidity and mortality warrant attentive multidisciplinary postoperative management. Early intervention should be initiated in patients with clinical evidence of cardiorenal syndrome based on its potential benefits in this specific population. A multidisciplinary approach for children with CRS should include a pediatric nephrologist in conjunction with a pediatric cardiologist, both working with a pediatric anesthesiologist in order to establish accuracy of detecting early signs and symptoms of CRS, intraoperative management, and postoperative success. Thank you.
We do have a question.
All right.
You see it, Jason, Jacob?
Uh,
If you go down to the bottom, you can hit the Q&A.
why did they wait? Is that the only question? Why did
Yes.
they wait a day? It was, I believe, a timing issue. It wasn't simultaneous at the same time. It was consecutive, and the day was only the difference of a midnight. The first case was done in the late afternoon, and then the renal transplantation was done after midnight. So while it seemed a day, it was only about 7 or 8 hours apart. Is that the only question? Okay, so it's someone put in the chat, bleeding instability, the kidney can go to another participant if the patient does not do well, as also reasons for why the two transplantations were separated.
Okay.
All right, thank you very much.
Dr. Nossman's still on the phone?
That's what I was going to say. I'm not sure if Dr. Nossman is
I'm
on or
sorry, I
not.
muted.
Go ahead, Bobby. Go ahead.
I apologize. So I'll reintroduce Dr. Cephalou, who's going to discuss an assessment of the role of non-opioid adjuvants in regional anesthesia practice.
Thank you. Hello, I'm John Cephalou. I'm a senior resident at LSU. This exciting talk is we have two very fantastic regional rotations at LSU. Next. Okay, so regional anesthesia has become a very important component of modern anesthesia practice. Adjuvants are medications added to local anesthetics that may shorten the onset, increase the duration and quality of the regional anesthetic. Regional anesthetic adjuvants have been studied by IV systemic, perineural, and topical routes. We review the most commonly used regional adjuvants for regional anesthesia. Next. First is dexamethasone. It's a long-acting synthetic corticosteroid studied in TAP, brachial plexus, ankle, and paravertebral blocks. Words decrease post-op opioid use and decrease post-op nausea and vomiting. However, some studies show increased or no change in opioid consumption. Interestingly, dexamethasone has also been shown to reduce post-op nausea and vomiting, but this also has to be preservative-free, and this can also be due to the actual systemic absorption of giving the same dose as you would IV when you give it perineural. NSAIDs and acetaminophen. There was a small study with lidocaine plus dextroprofen or acetaminophen and intravenous regional anesthesia that found a reduction in time of local anesthetic onset and prolonged duration of sensory aid. Questions still remain about the safety and efficacy of these two regional anesthesia, of these two in regional anesthesia, particularly with the question of neurotoxicity. And then we get to alpha-2 agonists, are more commonly used adjuvants. These are two I use really commonly, clonidine and dexmedetomidine. Two mechanisms, one of which is a known mechanism in which they cause alpha-1 and alpha-2 vasoconstriction of the local vasculature, reducing uptake of local anesthetic, and a newer mechanism in which is thought to increase potassium conductance in the A and C fibers, enhancing the duration of the block. But both prolong the local perioral IV, and evidence supports prolongation of up to 4 to 24 hours. I've personally seen 10 to 20 mics placed in a supraclavicular block last up to 24 hours. Pretty scary. Midazolam next. Midazolam is another interesting one. It's a short-acting benzodiazepine that works on GABA A receptors in the CNS and has some evidence for GABA A's outside the CNS, but the mechanism is unknown. However, there's been a new receptor identified called the translocator protein TPS-SO receptor that's involved in analgesia from midazolam and other benzodiazepines that's in the periphery. Perineural administration with local anesthetic improves the block intensity and duration, but there's still concern for neurotoxicity similar to with NSAIDs and acetaminophen in the blocks with perineural administration. Next up, we have our NMDA antagonists, and contrary to belief, ketamine still not been shown to have, there's been just limited data with ketamine right now for its use in regional anesthesia. And this is unfortunate because ketamine is shown to have sodium channel blocking properties and new opioid agonizing properties outside of the NMDA properties that it exhibits. For magnesium, magnesium has been more promising as another NMDA antagonist, and this is thought to help decrease peripheral excitability while also helping local anesthetics to increase the threshold for pain fiber excitation. It's been shown to prolong analgesia duration in femoral, interscalene, and active neurons, and shown wide margin of safety. As we know, in obstetric patients, we usually load them for gestational hypertension to get them to levels of anywhere from 4 to 10. However, caution should be taken with patients with severe renal dysfunction, as they are unable to clear it or have a reduced clearance of magnesium. Next, we have buprenorphine as a semi-synthetic partial opioid agonist, the kappa opioid antagonist. It's been used as an adjuvant for a variety of regional anesthetic techniques, such as neuraxial, intravenous, and blocks. It has been shown to significantly prolong the median time duration of analgesia for upper and lower extremity nerve blocks. Neostigmine has been low doses to have opioid enhancing effects, but large randomized control studies are still needed to assess the efficacy and safety of the cholinergic side. Its use in epidural and intrathecal routes with local anesthetics, opioids, and ketamine significantly enhances the analgesic effects. And then we have sodium carbonate, and this is one we know of for quite a while. It's theorized to hasten the onset of local anesthetics and increase the depth of the block by alkalinizing the local anesthetic to the unionized form, allowing for the drug to cross the lipid cell membrane. But the evidence is still not consistent in proving that not been approved for clinical use in regional nerve blocks. In addition, you must use with caution as it is an alkalinizing agent. And then next, we have epinephrine. Epinephrine is our most widely used adjunct as it reduces local anesthetic toxicity, prolongs the duration of sensory and motor blockade, helps to detect intravascular injection, and increase the velocity. This prolongation in sensory and motor block has been demonstrated with axillary nerve blocks with lidocaine and brachial plexus nerve blocks with mepivacaine and bupivacaine. It is important to note, though, that epinephrine does not alter the duration of the onset of ropivacaine. Next. Practitioners taking care of patients in acute and chronic pain setting must be familiar with regional anesthetic techniques and medication administered with them, as well as adjuncts. Regional anesthesia with ultrasound technology and newly studied and approved adjuncts. Some adjuncts, such as neostigmine and ketamine, just need more evidence-based data before recommending their use as adjuvants. And then finally, addition of adjuvants may help improve patient safety, increase patient satisfaction, and enhance clinical efficacy.
All right, sir, thank you. This review is up for questions. Thank you, Dr. Sepulveda. We'll proceed on to Dr. Alex Pham. Liposomal bupivacaine and novel local anesthetic formulations.
All right. Let me see. All right, slides are up. So my name is Alex Pham. I'm one of the second-year residents at LSU presenting on liposomal bupivacaine and novel local anesthetic formulations. Next slide, please. All right, so just as far as the background goes, this new medication was arrived in the advent of the opioid epidemic, as well as complications of opioids, including what we're familiar with, nausea, vomiting, and respiratory depression. And also present just to treat untreated pain, severe untreated pain within 72 hours, given that it leads to a high likelihood of high morbidity, prolonged opioid use, and also possible conversion of acute pain to chronic pain, which led to the advent of the production of liposomal bupivacaine, or HTX-011. So this is a novel preparation allowing for the extended duration of action of local anesthetics. And the liposomal bupivacaine has the potential to significantly impact patient care by improving perioperative pain control. It's unique in the sense that it has a liposomal bilayer that encapsulates bupivacaine, leading to extended or sustained release covering up to the key 72-hour period, and can significantly decrease post-operative opioid consumption. We did review some of the, we call the SABRE bupivacaine, another depot formulation that helps in sustained release of bupivacaine from encapsulated bupivacaine in a biodegradable sucrose acetate isobutyrate bilayer. We'll review current phase 3 clinical trials conducted on what we call HTX-011 of this polymer that's composed of bupivacaine and low-dose meloxicam within these bioerodible polymers. The present investigation reviews pharmacological considerations related to the formulation of bupivacaine, current FDA-approved indications for its use, and future extended release of local anesthetic formulations currently under investigation. So our objective is to review the liposomal bupivacaine and new versions of the horizon for regional and chronic pain procedures. Our methods include many chart reviews and collaboration PubMed articles, as well as the use of liposomal bupivacaine in clinical trials. So long story short, after reviewing multiple articles, they had some promising results. In the inguinal herniopathy or hernia repair and the use of HTX-011, they found that 90% of patients were opioid free in the key 72 hours after surgery, as well as reported reduced, significantly reduced pain. This was also followed by similar results in bunionectomy surgeries, as well as total knee arthroplasties when compared to a placebo of saline or just short-acting bupivacaine HCl. So essentially what we have found is that there was some promising positive results of decreased opioid use and pain in these 72 hours. Current evidence supports liposomal bupivacaine used for infiltration in surgical sites. And a key thing about this is that they didn't inject with needle. It was more like placement of these polymer pearls so that as to reduce inflammation. because inflammation is what lowers the pH. And going back to pharmacology, bupivacaine has a pKa of about 8.1, far from normal physiologic normal state. So it makes it much more difficult to transfer across the bilayer. But if you add meloxicam, which reduces the inflammation, raises the pH back up, then it allows for bupivacaine to kind of extravagate along with the slow release from the hydrolyzed polymer. So this was seen in multiple studies, again, including the TKA, bunionectomy, and inguinal hernia repair. Essentially, this was gathered from phase 3 clinical trials, which basically revealed on everything that I would just discussed. So in conclusion, as implementation of regional anesthetic techniques continues to grow and become standard of care, clinicians need to be cognizant of the pharmacological and physiological properties of these medications used. Currently, it's not FDA approved, but it is near, from what I was reading in recent articles. The data still needs to be studied further, but the current data is promising. So hopefully we'll have something soon for these patients just to reduce opioid consumption and its complications. So that concludes my presentation.
All right, this presentation is open for discussion.
Yeah, so I was going to ask, in your review, did you find anything about the hotly debated topic for liposomal bupivacaine, which is the price? There's so much debate around that how it's so expensive and a lot of hospitals cannot afford it, or they have better alternative. And then I think the pricing models are also different depending on what sort of agreement the hospital has with the company.
Right, that's a good question. So the three or four studies that I reviewed did not focus on the price, just more on the safety and efficacy. So as far as price goes, I mean, pharmaceutical companies probably will pick the highest price, I would assume, but they did not bring that up as a sole measure. But as far as safety and efficacy goes, it seemed like it was a pretty safe medication, with the most common being nausea and dizziness. But otherwise, price itself was not discussed.
So do you think we can achieve the same results in terms of the motor and sensory level of the blockade and the duration of the block by using other much cheaper adjuncts that somebody just talked about in their previous presentation as compared to using liposomal bupivacaine?
So it's hard to say because when in these studies that I discussed, they compared it more to not directly blocks. I mean, more of like a placebo versus quick acting bupivacaine. But I think that from what the study showed, it seemed like I would surmise that it was probably similar efficacy, just because of the results had basically been achieved as far as decreasing opioid and pain in those 72 hours. So I think that was the key point, was that it had lasted a lot longer during the critical periods of needing opioid consumption. So in that regard, I would say that it was, if not just as good, if not superior. But these are just from limited studies.
Thank you.
Mm-hmm.
Thank you, gentlemen. Jacob returns to discuss comparing conventional thermal radiofrequency ablation and pulse dose radiofrequency ablation versus thermal RFA alone for chronic low back pain.
All right, thank you very much, Dr. Nussman. Hi, everyone, again. This was a research project that was done with the world famous Dr. Ashragi, Dr. Shaiban, and several other residents. So kick it off. Can you click next, please? So I know we mentioned it earlier about causes of low back pain and the associated impact that it has on Americans. So I'm going to talk a bit about low back pain and RFA first. So low back pain is one of the commonest reasons adult patients seek medical evaluation in the United States. Lumbar facet joint dysfunction has been estimated to account for about 15 to 45% of all causes of back pain in America. For this region, the sensory innervation of these facet joints comes from medial branches of dorsal rami at the spinal nerves at adjacent levels. Radiofrequency ablation, or RFA, is done with the following elements. There's a radiofrequency generator, cannulas with active tips, and a thermocoupler that serves to sense temperature and transmit radiofrequency energy. This current then enters the body at the tip. It generates an electromagnetic field and produces a spherical lesion around the active tip. The current then travels through the body and eventually reaches a grounding pad that disperses out of the body. There are three main types of RFA. There's low intensity RFA, there's cooled RFA, and there's pulsed RFA. Low intensity RFA is administered constantly for about 60 to 90 seconds at a specific temperature. Cooled RFA involves the use of a cannula needle that has saline rushing through it to cool the tip. And pulsed RFA is done with a signal interruption every half second, creating temperatures at about 42 degrees Celsius. RFA uses continuous heat at ADC for about 90 seconds to create a neurotomy lesion at the medial branch nerve that helps to interrupt nociceptive input, thus treating the chronic facet-mediated low back pain. In contrast, pulse dose RFA is performed in short pulses to reduce target temperature by allowing for cooling of tissues. And it's carried out in 20 millisecond pulses every half second so that the temperature doesn't exceed 42 Celsius. The duration of benefit from RFA treatments of low back pain is currently unknown, but with facet-mediated lower back pain, when and if it does occur, the process can be repeated, with many patients receiving multiple procedures with various duration of benefit. So for our retrospective study, we compared the length of time elapsed before repeating the treating procedures in patients who received RFA alone versus those who received the pulsed RFA immediately followed by conventional RFA. So the combined group. Next, please. So this was a retrospective review conducted on patients with chronic low back pain receiving the RFA of medial branches at the L3, L4, and L5 level. After receiving Ochsner IRB approval, patient data was collected over 7 years from January 2013 to January of this year. These patients were then divided into two arms, those who received the combined and those who just received the RFA treatment alone. Patients in each group needed 2 or more lumbar RFA treatments to be included in the study. These interventions were carried out by multiple pain management physicians at Ochsner Clinic. With some technique in conducting RFA may have varied slightly between providers, though it was not considered in the analysis of our results. Again, primary outcome measure was the average length of time between RFA procedures for each group. And additionally, non-RFA treatments were recorded to account for other intervention modifiers. So looking at some of the data, the medians, interquartiles, frequencies, and percentages were used to describe the entire population in terms of demographic and clinical characteristics, as well as the outcomes. That is the number of RFA treatments and days between, which we can see in table 1. And comparison of demographic and clinical characteristics and outcomes by treatments, that is RFA only versus RFA and pulse dose, were examined with Wilcoxon rank sums and chi-square tests, which is in table 2. And unadjusted Poisson regression analysis were also used to predict the number of RFA treatments in the treatment groups, which is also found in table 2. For this study, p-values less than 0.05 were considered statistically significant. Next slide, please. So the results of our study, we reviewed 112 patients who received RFA and 68 patients who received the combined treatment. The mean number of RFA procedures for the RFA alone group was 3, and the mean numbers of procedures for the combined group was 2.65, which was statistically significant. The average number of days between treatment groups in the RFA group was 412 compared to 388 in the combined group. However, this result is not statistically significant for our review. The maximum time between procedures for our RFA group was 1,876 days versus 1,994 days for the combined group. Both groups had a similar age and range. Range in age. However, the combined group had a more even distribution of females to males at 37 and 31 respectively, compared to the conventional RFA group, which had skewed more toward females at 69 and 43 males. Additionally, the non-RFA treatments between RFA procedures were not significantly different between the two groups. Next slide, please. So while comparing patients who received the combined treatment and patients who received only conventional thermal RFA, we did not find a significant difference in the time between repeat procedures or utilization of non-RFA treatments between procedures. There was a statistically significant reduction in the average number of RFA procedures in the pulse RFA and RFA group versus the RFA alone group. However, this result may not be clinically significant. The results of this study point towards seeking out other methods in which we can compare the groups to find clinically useful results. Further research could compare patient satisfaction in terms of pain scores and pain disability index scores, rather than looking specifically at the time between procedures. Additionally, we would like to review these measures with a potentially larger and more evenly distributed cohort, which may yield statistically significant results. Thank you very much.
All right, this paper's up for discussion. Again, this paper exemplifies the need for us to evolve away from the use of frequentist tests. Put your results slide back up, please. Wherein we're using the chi-square or the Wilcoxon-Rank sums, and we come up with a statistically significant value, the p-value, etc. Whereas then when we look at those three those three graphs, I'm saying, man, they look equivalent to me. The confidence intervals, the interquartile ranges, etc., are all very similar, unless there's something really dramatic in the y-axis that says above and below a certain value. Nevertheless, you did state that there may not be clinical significance. And how could we answer clinical significance? Well, basically, you look at a problem and say, what is the difference in change? The change in what you're looking at, the outcome, that would be clinically relevant. And I run this scenario a lot with students with their research questions by, say, picking you put a new drug into the market and it decreases the complication from 98% to 96%. Is that clinically significant? No. What if we drop the complication rate from 50% to 48%? Would that be clinically significant?
I don't really know.
What if we dropped the the complication rate from 2% to 0%? Would that be clinically significant?
Perhaps. I mean, it could, but a larger picture of the effects of implementing this new treatment would have on cost.
That's fair, because you got to look at treatment effects, and et cetera. But so I gave an example of a 2% decrease across from 100% down to 0%. So even that needs to be factored in. And then, of course, if we sit there and said, well, the outcome was mortality. Yes, that's big. What if it was nausea? Less. So, and only clinicians, not statisticians, can make those determinations.
I agree.
Okay. Well, I'm very thankful tonight to have participated in this research seminars, this research day. I know I learned a lot. There were new medications that I'd never heard of. that certainly need further investigation by members of the society. I also know that there were new procedures introduced tonight that need further investigation by members of the society. And that's the beauty of research. That's why I thoroughly enjoy doing research, is you get to do new things in our specialty. And I'm very thankful for that opportunity. Dr. Kovaleski.
Hey, and Bobby, thank you for moderating this. You're obviously born to do this and well practiced. So thank you. And I just wanted to make a couple of observations. It's not particularly scientific, but I just think it's interesting that just over the years of the internet, just over the last 20 years, the idea of telemedicine came out very quickly using email, and then when video, FaceTime, chat, Skype type things started happening, that people thought to do that immediately. And of course, what was the government's response? And hospitals and lawyers and regulators, they immediately started regulating, forbidding people from doing it, medical boards cutting people's heads off. And it's just kind of, I think it's sort of interesting. Now, of course, we have to do it the right way, but it's just very interesting to me. Maybe this is a significantly good outcome from coronavirus, that we've finally kind of got off our medicine. It's hard to change things in medicine sometimes. And this pushed us off our butts maybe to get to this thing. Doing this, just even doing this, learning this way this is possibly more efficient and for everybody. And so anyhow, it's
certainly covered.
Yeah, it's great to see this. I really want to thank all the residents and students that participated, did a great job. I definitely learned things too. I noticed in our participant list, we've got some of our LSA officers and directors out there. I see Brett Aaron, Dom Carollo, Jimmy Colon, Julie Broussard was on there for a while. These are the people that are leading the Louisiana Society of Anesthesiologists, and they, care enough to be here for you, students and residents. There's a couple of other attendings out there I see. Always wish we could get more attendees. There's hundreds of attendings in this state. There's another 100 or so residents and medical students. Wouldn't it be great if every one of them was on here? We'd have 400 or 500 people on this.
And I think we had 2 clinical investigators.
Yep.
Pain section.
Yep. So anyhow, that's all I have to say. I really want to thank you. I look forward to doing this again somehow or something similar. Jan is going to tell us about, there is going to be, there's a competition, some voting, some nice cash prizes, cash money. That never hurts. And Jan is going to tell us about that a little bit later. I think, Craig, do you want to go next?
Yeah, I'll jump in if you don't mind. So first of all, no wagering on the competition. It's not allowed, but I'm Craig DeLanzak. I'm a past president of the LSA and had the privilege of being the ASA Assistant Secretary, following Dr. Kovaleski, an LSA president, and Dr. Nossaman, a past LSA president as well. And I wanted to thank Dr. Nossaman, who is a master moderator, did a fantastic job. He's a underappreciated, underutilized resource in Louisiana. And you guys should take full advantage of his wisdom and expertise and help to move this field forward. He made a comment about tonight you're advancing medicine, and you are. And you guys, the presenters, were professional and polished well beyond your years. And we are very proud of you. We LSA, we your institutions, and we ASA. And if you know the mission statement for ASA, it's advancing the practice and securing the future. And you're doing this tonight, is advancing the practice. It's also securing the future. We talk about advocacy, professional advocacy at your institution, at your system, at your facility, and also at the state and national level. The research you're doing tonight, the things that we do in the science of anesthesiology doesn't happen without the professional advocacy, and the professional advocacy does not happen without the research that's going. These two things go together. It's hard to advance a field if we don't have the best and brightest in the field. So thank you for what you're doing tonight. I want to thank Dr. Nosman. I want to thank Dr. Kovaleski for pushing this forward. Thank the LSA board for doing this as well. But someone that doesn't get the attention she deserves is Jana Piquet, who is our executive director. Jana is gaining some national cred through the work that's being done at LSA. So I encourage you to get involved with the LSA. And if we're not for Jana, this wouldn't happen tonight. And this wouldn't happen tonight for your work. So thank you very much. I appreciate it. I thoroughly enjoyed it. Sorry, I got pulled away for a little hospital duty for a couple seconds, but missed all but maybe one presentation. So thank you. Please reach out to Dr. Nosman, Dr. Kovaleski, any of the LSA board members, and myself for anything we can do to help you to advance your career. And with that, I guess I'll turn it back to you, Dr. Kovaleski.
Okay, I also am getting a note here from Brett Aaron. Jan, is there any way to let Brett talk?
Yeah. All he has to do is unmute himself.
Okay, can you hear me now?
We can hear ya.
Great. I just wanted to bring everyone's attention to a message we received from our leadership at the ASA about some changes at the VA. A few years ago, they wanted to let nurse anesthetists practice independently there, which generated a tremendous outcry from all sorts of healthcare providers and patients. It generated well over 200,000 comments, a record in the VA system. And the VA leadership relented and dropped the issue. Recently, they have changed course, and without any comment period, I think it was yesterday or today, they implemented a change that allows nurses to practice, encouraging the VA hospitals to let nurse anesthetists practice independently. This is not good for our patients at the VA system.